When it comes to allogeneic stem cell transplantation in refractory AML, I think this has been made popular more than 10 years ago, thanks to the so-called FLAMSA or FLAMSA-like regimens. So the concept is about including as part of the preparative regimen before transplant two sequences. One initial sequence is about chemotherapy, trying to debulk the disease, trying to eliminate as much as we can in terms of leukemic cells, then immediately followed after 2 or 3 days of rest by the conditioning regimen, and then infusion of the graft. And once engraftment is achieved, the philosophy is also about delivering some form of therapy after. Of course, donor lymphocyte infusions can be done, but these days I think we are using more and more targeted therapies. Hypomethylating agents are widely used. FLT3 inhibitors are also used after transplant in the FLT3 ITD population, but now also we see drugs targeting the apoptosis pathways like Venetoclax. So clearly, I believe the results of allotransplant for refractory AML will continue to improve over time, and we owe this to the synergy between the transplant procedure itself, the allogenic immune effect, but also to the novel agents, novel mechanism of action. So joining forces there in order to control the acute myeloid leukemia disease.